Hello, welcome to this second part of the recovery-oriented care presentation. This second part will only deal with the case study related to part one, which was the theoretical recovery-oriented care presentation. My name is Lori Thompson. You can see my information on the screen in front of you. If you have any questions or comments about this presentation, please feel free to reach out to me either by phone or by email. So we're going to take a look at a case study related to Carla. Carla is 32 years old with an extensive history of repeated presentations to emergency departments and police involvement. Her most recent admission, she was picked up by police. She was psychotic, running down Jasper Ave naked, screaming and threatening strangers on the street. Carla uses methamphetamine, and she is not interested in quitting or reducing her methamphetamine use. She was discharged on a CTO. Her treatment includes biweekly Clopoxyl, IM, and oral medications. Carla does not believe that she is ill and does not want to take her medication. Carla reports the medication makes it so that she can't think and it makes her tired. She has little to no contact with her family and is currently living at Dwayne's home. She will need to find some new housing as they are closing in the near future. She has been evicted from multiple housing programs in the past and is on the wait for permanent supportive housing, which would be years. Even while on medication, she remains psychotic, which is worsened by her substance use. She receives AISH but thinks she's owed millions by multiple record companies who have sold her songs to famous musicians who she hears singing them on the radio. She wants to sue the artists and recording companies for stealing her songs. She tolerates visits from the team because of the CTO, but plans to get off the CTO and never take medication again. The client in this case study, Carla, is not an optimal client to create a recovery-oriented care plan. Number one, the stage of change that she would be in would be pre-contemplative, and that is definitely not optimal for motivational interviewing, nor is that optimal for recovery-oriented care. Number two, she also has delusions, and therefore treatment may be needed prior to a recovery-oriented care plan. Example, increasing her medications or changing her medications, or even thinking about some cognitive behavioral therapy. There are various cognitive behavioral therapy techniques that can be used effectively in schizophrenia. One of the techniques known as cognitive restructuring includes challenging the patient to come up with some evidence to prove that their beliefs are real. This is one of the many techniques that may assist the client to realize that they have delusions. Though Carla is not the optimal patient for a recovery-oriented care plan, we don't often get optimal patients. And so this case study will be used to show how recovery-oriented care can be used with all clients regardless of the stage that they're in. So there's a lot going on with Carla right now. We need to know that recovery-oriented care is not a quick fix. Working on the plan for Carla will take years, if not a lifelong journey. The care team goals may not match what the client's goals are, but there are some commonalities, such as stable housing. Is there anything that we can work on to establish trust with Carla? Are there any small steps that we can do to help Carla? If we look at the left side of the table, we can see what the care team goals potentially could be, and on the right side, we potentially see what Carla's goals would be. We need to pair these two together to come up with a comprehensive care plan for Carla. So step one is to sit down with Carla and come up with a care plan. You will want to explain to Carla what the purpose of the care plan is, that we want to use her goals to come up with a care plan for her future. We want to tell her that a care plan is a tool that you will use together to help her create a plan to improve her health and wellness, to live a self-directed life, and to strive to reach her full potential. Not all clients will want to do this, and as clinicians, we have several tools at our disposal. Even if this tool doesn't work at the moment, we should always have a recovery-oriented focus in the care of our clients. This means focusing on what Carla wants. But let's say that Carla agrees to try the recovery-oriented care plan. Once Carla has filled out the top portion, we want to explore her answers. So let's focus on her not wanting to take her medications. She tells us that she gets tired and she has headaches, she can't think when she's on the medications, and she often forgets to take her medication and doesn't feel that she's sick enough to have to be on these pills for the rest of her life. Always remember, your conversations with her are planting the seed for further growth. The other thing that we want to take a look at, are there any other reasons that maybe Carla has not listed as to why she may want to not be on the medication? Is it related to how she's taking the medication? Is it related to other side effects such as weight gain that's going on? So the big question is, why does she not want to take the meds? And this will take a lot of exploration. We want to listen to the concerns that she has. No one really wants to take medication. They need to see the benefit in order for them to be adherent to the medications. But as clinicians, we can make taking medications easier by listening to the concerns and issues a client has with the medications, and then providing any education or options that may be of assistance. So we would want to go through the different side effects of the medications and how Carla's feeling. She says she's feeling tired and she can't think, so we want to explore reasons for this. Is it the medication that she's on? Is it side effects of the meds? Is it related to the illegal substances that she's also taking? Is she taking any over-the-counter medications, any alcohol? So there would be a lot of conversation with Carla about what the side effects, the reason for them, and what is her feelings about those side effects. Also with the headaches, we want to do a bit of an exploration as well, determining what her fluid intake, are the headaches related to dehydration, or is it related to a side effect of the medication or something unrelated? What is her sleep hygiene like? Is there something that we can do about that? Are there some over-the-counter pain relievers that we could suggest for her to help with the headaches? We usually find that if we can make things easier for patients, they may be a little bit more apt to take the medications. She also says that she doesn't feel sick and doesn't really have an understanding of why she's on the medications, and this may be related to her delusions. We can provide education or talk to her about treatment for the delusions. Is this something that maybe is not going to work out for Carla? Should we be looking at a medication change for her? So let's look at the care plan. Though Carla has 2 goals, this visit we're going to focus on a portion of one of her goals. You will notice that the clinician uses the answers to the question, why do you want to stop your medications, to help Carla come up with some goals. You'll also note in red where Carla's motivation is for change on a scale of 1 to 10. Though she hasn't 100% agreed to the plan, she is willing to attempt some of the options, and you may have a situation where they're not willing to attempt anything. We are using her goal of not taking her medications to motivate her to make changes that will improve her health and wellness, help her live a self-directed life, and reach her full potential. It is not a plan that I as a clinician would want for her. It's what she wants, but with some clinical guidelines. So she has decided that she doesn't want to take her medication and get off the CTO. She feels that her strengths are being adventurous. She has lots of friends and she likes to write songs. And her needs are to get her doctors and nurses off of her back. All of this should be written in Carla's handwriting and in her own words. So some of the things that we came up with as a goal, because we do not want her to not take her medication, but there are some ways that maybe we could ease the taking of the medication. So if she was dehydrated, getting a water bottle, sipping some water, that will definitely help her with the medications and metabolizing the medication. And then the next appointment, we can ask her how that's working. She's willing to increase her water intake to see if that does help with the headaches. We want to track in a journal or phone when she's the most tired to see if a medication change needs to be done, or maybe the medication needs to be taken at different times of the day. And we'll review that in the next appointment when we have more information. We have also said that if no improvement happens, we would discuss the medication change with the doctor. Carla is really not all that interested in that because she doesn't want to take any medication, but we'll review that again in the next appointment. Remember, we're planting seeds. Something that Carla is quite interested in doing is looking at alternatives or additions to the medication. She's not so happy about the additions, but are there some alternatives? So at this appointment, we would provide some education on alternative therapies that she could look into: CBT, family therapy, and exercise. And we can provide her some resources that are peer-reviewed for alternatives to the medications that she's taking or additions that would help her decrease the medications. And we also want to deal with what she is saying is a side effect that she's not comfortable with, which is the headaches. So we can provide some education on over-the-counter pain relievers. We could provide some information on maybe meditation. We could provide some information on the hydration and how that affects her headaches. And all of this we're going to take a look at her next appointment. At the bottom here, we would check off the box and we would give a copy of this to Carla so that she knows what to expect for her next appointment and she knows what she could be working on throughout the week. So Carla returns a week later. She brought a Bejeweled water bottle to show you, but she says it isn't helping with the headaches and neither are the Advil. Carla has looked online for some alternative treatments to schizophrenia and wants to try some yoga and vitamin D. Some of the other things that we know about Carla is she feels that one of her strengths is having lots of friends. So we can build on those goals and strengths that Carla has. She wants to maintain friendships. So are there some ways that we can encourage her to attend some self-help groups? Maybe the Hope and Wellness Center has some yoga classes she could join. Is there other self-help groups once she's there that she might be interested in joining in that may meet some of her needs? So because it's her second appointment, we're going to adjust her recovery care plan. Her hope and goal is to still not take her medications and get off the CTO. Her strengths are also being adventurous, lots of friends, and writing songs. That hasn't changed. But what has changed with her is to get more information from the nurses and doctors, which changed from getting the nurses and doctors off of her back. So we would see this as a positive moving forward, and that she was moving forward in the change theory. We can see that she did buy the water bottle. She is drinking more fluids. It really wasn't working. It's completed, so this could come off of her care plan. She decided that she wanted to track in her journal when she's more tired because now she's interested in how the medications are affecting her tiredness, and so we've moved her along on the 1 out of 10 scale a little bit further, and we're going to review that again at her next appointment. She's a little bit more interested in looking at some medication changes now that she's done a little bit of investigating and had a little bit more education. And we have decided now we'll make an appointment with the doctor so she can have that conversation. We've also changed the scale for discussing alternatives of her medication with the doctor at this appointment. She's 10 out of 10 for this because she really wants off the medications and she's interested in looking at other things that might help her with her schizophrenia. At the moment, we're holding this. And taking the pain medications when the headache starts, she's going to continue on that and we'll revisit that again. Again, now that this has been updated, we would give another copy to the patient and we would take a copy for the chart. We would then need to transfer this information over to Connect Care, and Heather is going to show you that after this presentation. So what if Carla doesn't want to follow her care plan? What if she starts to achieve her goals and then decides that she wants to give up? Or what if she originally she shows up at the appointment and she hasn't done anything? She's absolutely refused to do anything, even though it was her words for the original care plan. Recovery-oriented care is about engaging the patient on their recovery journey. There are no great answers here. This is a process. It's not a quick fix. I'm sure all of us have made resolutions for change that we have not adhered to. Some of those decisions have huge consequences, while others have very little. We're doing the best that we can with what we've got, and that's the same as Carla. So the first thing that we would want to do is, can we assess the reason why she has decided that she's not either going to follow the care plan or she's not interested in doing specific things. Maybe there's a new issue. Maybe she's moved on. Maybe she's just having a bad day today and the next appointment things might be a little better for her. Maybe her goals have changed. Do we need to revamp everything? Also, what are the consequences of the patient not following her goals? Maybe not doing one of the things for one day isn't that big of a deal, but if she's doing things that are really affecting her health, we may need to revisit how much of Carla's goals can be fulfilled. We need to pick our battles with Carla. Any move forward is cementing that relationship or partnership that we have with Carla. And we need to develop that trust with her in order to help her move forward in her recovery-oriented care. Does the client want to sit down and go over the care plan just to adjust? Were the goals too big? Or maybe since it was the first time she was doing it, she didn't really think of the consequences of her goals. Now she's maybe had a chance to rethink things. Was the plan not what the patient wanted? Sometimes we may push our own wants on the patient, and that's part of our clinical journey. We really need to pair our clinical desires for this patient to what Carla's desires are and come up with those commonalities so we can help her in her health journey. If the client really is not interested in their recovery care plan, we want to point out that it was the patient's own handwriting and these were the goals that they had decided on. Explore if the goals can be broken down into even smaller parts, or do they need to be changed altogether? Were their SMART goals done properly to ensure that they're goals that Carla can complete? And also, is there a power imbalance? Does the client lack control in their lives, so therefore they're exerting control in the way that they know how to by saying no to this care plan? How do we get that power back into Carla's hands so she's making the decisions for her life? So now let's look at all three concepts together. Recovery-oriented care, language, looking at change theory, and motivational interviewing. So Carla is not taking her meds and she is not interested in making a goal. So when we take a look at change theory for pre-contemplation, contemplation, and preparation, when you think of what you would like to say or write for Carla, for pre-contemplation, that stage of change, it presents a limitation to motivational interviewing. If the patient is in this stage, they will not consider that they have a problem and therefore are very unlikely to be receptive to motivational interviewing techniques or to recovery-oriented care, because how do they create a goal for something they don't see as a problem? It is important that motivational interviewers are well trained in the approach to be taken when handling these patients. Well-intended messages can have the opposite effect of pushing that patient away or causing them to actively rebel. In these instances, discussing how the issue may be affecting the patient must be handled very delicately and introduced carefully. Suggesting less harmful ways of dealing with the client's issue and helping them recognize danger signs might be a better approach to plant that seed to aid their progression to the contemplation stage. So it's very difficult in pre-contemplation. One of the things that I would suggest in pre-contemplation is a question that you could ask Carla is, can you tell me why you don't want to take your medications? We should be considering harm reduction at this stage. We could be talking to Carla about testing her doses of meth for contaminants. We could be talking about using supervised consumption sites. We could be talking to her about decreasing the frequency of her illegal drugs, maybe not mixing her methamphetamine with other substances, and maybe talking to her a little bit about why she wants to take the methamphetamines. If we felt that, in this case study, we know Carla is in pre-contemplation, but if we felt that Carla was moving towards contemplation, some of the things that we could ask her is, could you tell me some of the pros and the cons of not taking your meds? So she can explore what the ramifications would be of her not taking her medications. And if she was in the preparation stage, we would ask Carla, how can I help you remove some of the obstacles that prevent you from taking your medications? And then if we move forward to Carla is going into the action maintenance phase of change theory, and Carla is taking her medication. In the action phase, we would say something like, I see how hard you are working to achieve your goal. What is the hardest part? If Carla was in the maintenance phase, something we could say is, wow, you've taken your meds every day for 2 months. Look at how far you've come. Do you have a plan on how to prevent you from reverting back to not taking your meds? And then if Carla was in a relapse stage of change, we could ask her what are some of the things that she's learned about taking the medications. What could she do next time when she tries to make this change? Because there would be some learning from that relapse. So what do you think? Do you see any barriers to use? Some of the barriers that we have heard from other staff would be related to consistency, ensuring that each staff member is doing this care plan exactly the same or with the same intent, with the same type of training. If people are doing things differently, it does make it very difficult for Carla if she's coming in to see several different people and everybody is using a different tool. The other barriers that we have heard about is time. This does take a lot of time in the beginning, but when you think about how much time you're spending on a patient and they're not moving forward, this may help you in the long run. It's definitely very heavy in the beginning. And it's only one of the tools that is out there that will help you, but we should always have that recovery-oriented care focus in our mind. What are the strengths that Carla has? What are the goals that she wants? And let's try to work with her rather than pulling her along and forcing her. We also hear of a barrier of we get pushback from clients. They may not like the change, or they may not be invested in the process, or they may not understand the process. And that's fine. This isn't a great fit for absolutely everybody, but it's just another tool in your toolbox. And the other barriers that we see are related to cognition of clients. They may not have the capacity to understand what recovery care planning is. What we would suggest is going to the thought bubble care plan, which helps you have a conversation with that client and have a tool there so that they have a visualization of what they're doing. These are some of the barriers that we've heard about. You may have other barriers that you're thinking about, but your team needs to sit down and work through these solutions together to come up with a plan that is consistent for your team. The other question is, how can this be supported by your team? And the support that we know of is using those consistent tools. Connect Care will have a care plan in there for you so that everybody knows how to use the care plan. Everybody is following the same plan. The paperwork that I've provided to your team, you can use those tools and you can develop your own. So speak with your management team to come up with something that is a consistent tool for everyone. Other things that will help support this is embracing change. Change is very hard. We're used to doing the same thing the way that we've done it before. It's a lot harder to step outside of the line and try something different. But embrace that change, and if you need support, you have your management team, and always feel free to contact the clinical nurse educators. And do understand that everyone, no matter who they are, clients, patients, staff, all of us have wants and desires that can be framed into goals. And it does take a little bit of work to make those into goals that will be helping that client move forward. Some of the practice traps that we see related to this practice. Jeopardizing collaboration and safety by becoming the expert and telling those that you're supporting what they need to do next. That is so hard. We know that our clients are making decisions that are negatively impacting their health, negatively impacting their lives, negatively impacting their relationships, and stepping in to try to help them is, of course, what all clinicians want to do. But sometimes we jeopardize that collaboration by stepping in and stepping in to be the expert. The person who is the expert of their own lives is the client themselves, and we need to partner with them rather than being the expert and telling them what they need to do. The other practice trap is not tailoring the approach to the client. We're used to doing what we've done for a long time, and it's very hard to make that change. So we need to embrace change and find out what approach is going to work for the client. And it may change throughout the client's journey as well. Another practice trap is sitting down with the client and talking to them about what they need to do without first asking them what have they already done. I would assume in Carla's case, she may have tried to quit the methamphetamine already, and there may have been multiple attempts for that. Without asking her about that and just moving forward trying to get her to stop is going to jeopardize the relationship. So getting a really good history from your client, finding out what they have done already, what has been successful, even if it's in small bits, what has been unsuccessful, and working with that to come up with a plan moving forward. Another one of the practice traps, if we take a look at all of the things that are going on with Carla, there is a lot that we need to do with her, with housing, with relationships, with drug abuse, with taking her medications, with her legal information, and it can seem very daunting, not only for the clinician, but for Carla herself. So what can be a quick fix? What can be a stepping stone for Carla to plant that first seed of moving forward in her journey? And we may not be able to work on everything all at once, but what can we do that gets her the safest first? The other thing that we fall into as a practice trap is being too general or not providing enough direction or enough support for the client. Making sure that those goals are very, very small, very specific as to what the client needs to do to move forward. So what's in your toolbox? There's a lot of things that we've been talking about. Your attitude being welcoming, hopeful, accepting, unconditional, sometimes a sense of humor if that works. Our approach needs to be strength-based, person-centered. We need to have active listening, be engaging, and build rapport with the client. Our knowledge and skills, there's lots of things that we have in our toolbox: the stages of change, harm reduction, concurrent capable, cognitive behavioral therapy, motivational interviewing. All of you have many, many tools that you use, and it's just essential that we look at what can be individualized for that particular client, and then we need to document in Connect Care so that everybody is aware of what's going on with that client. Some of the takeaways I hope that you get from this is recovery-oriented care is a lifelong process. It focuses on the strength of the client and gives the client hope. It is a mindset of the clinician rather than being a tool. The change, for other takeaways, change is a process and change is hard. We must meet the client at their stage of change. The language that we use matters. It matters what we say out loud. It matters what we say in our head, because that comes out in our nonverbal. It also comes out in our verbal to the client and can sever relationships. And it also matters what we write down, how we write down what's going on with Carla. The other thing is motivational interviewing. It uses reflective listening and those open-ended questions rather than trying to be the expert in the client's life. We try to get the client to be the expert in their life, and we believe that. Motivational interviewing allows the client to change their own mind. And I hope you got a lot of takeaways out of this. Thank you so much for your time. I hope this has been of a benefit to you. I'm now going to end the presentation, and we're going to take a look at Carla and the care plan and put it into Connect Care. Thank you.